Excited just to have this conversation with all of you. I just want to kind of also talk a little bit before I ask the question. As we think about some of the barriers that we experience, like we know we can't remove a tribal community, right? Sometimes when we're looking at grant applications or opportunities, it's like, these are unrealistic barriers for our tribal communities, and that, you kind of touched on that. So again, thinking about that in mind, and I guess we'll just start here and then work our way down if that's okay. What barriers do you encounter in working with some of your tribal communities?
I think for us, one of the biggest barriers is we've done a very good job about getting people interested in screening, but we have a bottleneck of colonoscopies. We have, colonoscopies are not available throughout our state, not on a continuous basis. And so I can give an example. There's one region where there's 8 colonoscopy appointments twice a year. I have 1,200 people on the waiting list who have been contacted, who want to get screened. And there's more people, turning the age every year. So for us, the colonoscopy is a major barrier.
I would say that staff shortages and turnover have been a huge issue because it creates this situation where there's so many competing priorities for the persons who are working in that organization. Also probably identifying the persons in that organization who have the passion for the topic, as well as the authority to make decisions and make change.
And a lot of it is what you said as well. I think, too, it's just the SDOHs. I think I was going to be doing a talking circle at Grindstone Reservation, and they had a COVID outbreak. School was closed. They had no water in their community. The tribal office was shut down. The reservation where I'm from, sometimes fires, winter storms happen. So I think a lot of times they're intentional to get screened, but there's a lot of things that happen in everyday life that stops them.
Yeah. One of the barriers I was thinking about in one of our research projects is to help providers feel empowered in some of the knowledge that they know when talking with providers. And to be able to bring this project to this large health system that has a lot of interaction with tribal communities, and to be able to see, we can bring cultural training to them, and to be able to lean on our tribal leaders to bring that information into this large health system is just very promising. And so kind of next question are, what are some of your successes in working with tribal communities? I think that was such shock value what you said, and that's real, even in, the mainland, the lower 48, when we think about access to screening, a lot of times you'll hear Native people say, don't get sick at the end of the funding period because there's no money to refer you out. So again, just similar stories to that, but I think leaning in on what are some of the successes.
I think a success for us, back in 2013, the Alaska Tribal Health System convened a group of experts from Alaska and also Mayo and other outside, and looked at the data, looked at the higher rates among Alaska Native people, and made a collective decision to start screening at age 40. So back in 2013, it was still age 50 for nationally, and that was something that at the time, it wasn't going to get covered by insurance, it wasn't going to get covered by anyone else. Our system, our leadership decided that we wanted to make a change and try and, address this burden. And I think that as a policy decision, real money was put into it and continues to be. Now that the age for general screening has lowered, it seems less shocking. But I think those kind of policy decisions, adding more screening tests available, trying to figure out what we can do to increase screening. I think those have been some of our successes, is just getting more options available and figure out how we can get it best out to communities.
I would say one of the things that we're most proud of, at least, when we first start working with these clinics, it really is a very clinic-focused program, but one of the things that we've been able to do is help facilitate relationships and collaboration with local public health as well as tribal health educators. And having all of those people come to the table for every TA call has really helped them address some of the needs with finding patients, educating patients in the community, because so many of of the patients that need to be screened aren't coming in the door unless they have an acute condition. And so we need to meet them where they live, where they work, where they play, definitely in the community, and those other entities, public health and tribal health education, have a natural ability to do that where the clinic staff is kind of limited to their setting.
There's been a lot of successes with working with Tribal Clinic, and again, I think it goes back to culture is prevention. I think, doing talking circles, having that tribal liaison, and during those talking circles, when they're doing screening, giving out FIG kits, they're also beading. They're able to bring their aunties, uncles, cousins. So again, integrating that culture is prevention has been a big success.
Yeah, I think that's been one of ACAF's successes for colorectal, and you're shaking your head, so I love it, is our blue beads in March is really, using beading to have that conversation and who can come into that conversation. So thank you. Excited for this next question, which we'll just get right into. So how can NCCRT members partner with or support tribal orgs and clinics in their colorectal cancer screening work?
I think one of the things that impressed me the most when I came to this meeting, I think 3 years ago, was just the knowledge and expertise that's in the room. And that has been something that I feel like I need to draw upon, and I try to. So expertise in data, having people that have access to other systems, what has worked other places. I'm a big believer in successfully leveraging other people's work. So I think that that's a really important, is just having those conversations, figuring out what works and how we can then use it. So I think also the opportunity for research. I think it's been interesting how research and programs, if you call it implementation science, all of that has been really helpful in the work that we do. And so I feel like those pieces I really learn from others, and I appreciate it.
This is my favorite question too. So when I think about how can all of you get your foot in the door at a tribal community, I think my answer would be in building relationships. You need to start well ahead of when your project becomes available or when it's funded. And so I would encourage you to invite tribal leadership, the members of the clinics and hospital staff, as well as administration, to be a part of your stakeholder groups, of your evaluation teams for other projects that you're doing, so that when it comes time and when you have funding to assist on a tribal community, that you already have that relationship built. You've got connections with the people who are able to make the decisions, able to sign those agreements, and who have the knowledge of who in their communities are appropriate to be included on those project teams.
Yeah, to work with those tribal communities, it's really important to reach out with that Indigenous knowledge. I think it's not used as much, or it's not valued as much, and Indigenous knowledge is so important, and there is a lot of mistrust with Western health medicine and our tribal communities, but that's why Indigenous knowledge is so important, and that's really going to help build those relationships, calling in those tribal liaisons. It's going to really help build and grow.
Yeah, I think that's great. I just want to add again and emphasize how important it is for all of us to be able to partner. I think this is my maybe third or fourth conference I've seen Diana at in the last year, and it's our organization is only 22 people, and so we're just stretched thin, and we want to partner with everybody. We want to make sure we're meeting our funding requirements, and there's just not enough of my staff to be able to really get out there when we get those requests that aren't tied to our funding. And so how can we really lean on our partners that are also doing the work and that want to do the work? Not that I don't like seeing you, I love seeing you. Okay, I got one more question. How do you plan to build on your current work? What are some of the future directions would you like to see in our collective work to increase colorectal cancer screening and reduce the burdens of colorectal cancer in tribal communities? And I can totally repeat that.
I think some of the things that I would like to see, I definitely want to see an expansion of screening. Although we have a 70% screening rate, It varies by region, so looking at regions in my state that have less people screened. Building on research, I think we need to know more about why it's higher in Native people. I think that's a vital need. And then also just growing the relationships that we have with other people. I think that all of those things are really where I'd like to see things going. I have an application in right now to NIH to look at risk factors for colorectal cancer among Alaska Native people. So this is the third time I put it in, so you keep trying. So whichever ways that we can to leverage partnerships and find creative ways to fund this kind of work and fund navigators. I think that it was brought up earlier, but if we don't have navigators, we don't have screening. You can have an endoscopist standing there with his scope at the ready, but if you can't get the patients in, they'll just be standing there.
So our work is very much more at a local level. We're working directly with clinics in their own facilities. And so one of the things that came out just last Thursday from IHS is that they have approved a new EHR. So they will be, GDIT will be working with our tribal communities to implement a Cerner product over the next 10 years. So this is a long period of time, but we've really found, we've had, of the 15 non-tribal clinics we've worked with, 10 of them have changed EHRs during the time we've worked with them. And one of the things that we've learned is that it's really easy to think, okay, so we're going to have a new product in a few months or a few years, therefore we can kind of, like, we don't need to do this right now because we don't need to take really good documentation because that's going to get easier, or it's going to get better in a short time. But the fact is, when they do the best job that they can documenting that information now, the transition to a new product is so much easier. And so we really feel like preparing for that transition is going to be really important. And I also agree with you, coordination of care is just such a huge issue. So really working on closing the loop, being able to collect and document that historical data and results from colonoscopies that are done off-site.
Working with a lot of the tribal clinics, from the feedback that they gave me, is really number one that they want to move forward in is understanding the data. I know a lot of tribal health clinics struggle just looking at their internal data. And secondly is really multi-screening. So a lot of times they're holding mammogram events, or they're doing something specifically for colorectal, but really kind of working with those clinics because they have a high turnover for staff. They are doing a lot of community events, but how can we combine some screening? So really working with the tribal clinics on multi-screenings.
Yes, I know somebody in Minnesota that wanted like this this mobile CRC machine to drive around Indian country, which I think would be amazing. I just want to stress again, hearing that you put that app in 3 times, and I'm sure a lot of us in the room have had to go through that. But again, there's not enough PIs in Indian country to lead our projects. So oftentimes we're leaning on institutions, academics to be written in at like 15, 20%. That really does not take us very far. So whoever can fund her. Just kidding, she didn't pay me. But it's hard. I have some of my staff that are just on like 6 different projects, and that just does not do justice for us and then the work that we really want to do. So that is our last question, and I know we are ready to open it, and it looks like we have about 20 minutes.
Can I ask a question? So I know you have your hands full enough with the Native American population, but if you go back far enough, obviously indigenous people didn't pay a lot of attention to borders. And so I'm somewhat familiar with some of the Native Canadian populations, which share, depending on which area of the country Canada has a wide border to, similarities and tribal similarities depending on the area. But the Canadian system is somewhat different. You have provincial programmatic screening. Any idea or any information about whether the kind of diversity among incidence and prevalence or rates of screening and mortality for colorectal cancer among Native Canadian populations who share, I know there are Sioux, I know there are Iroquois in the East. Any idea? No, okay, just,
I
I think it's an opportunity for research because
I mean,
it's,
I think I can say, so we worked on a paper, because I had always said Alaska Native people were among the highest rates in the world, and I was like, we need to write a paper so that I can actually document that, and so that's when we did the analysis with some colleagues at CDC of Alaska Native people having the highest colorectal cancer rates in the world. And in doing that paper, we looked at country level estimates, and we were trying to look at other indigenous people in other countries. And it was incredibly challenging, and especially for Canada, because race is not, ethnicity is not a captured field in some of their data and cancer statistics. And so, you know, it's one of those things where if you don't know, you can't measure it, and so you don't know. And so I think that I would very much like to know more about, you know, the circumpolar north is where the countries that border are sort of around Alaska. But I think that that's a good question, and I don't know that there's been analysis. So if anyone has done that kind of work or interested, please see us.
yeah, basically, because there are tribal similarities. At least I know of a couple of tribal, you know, similar tribes in the central Canada, central U.S., and eastern. So it'd be interesting to see.
Arizona is home to 22 tribes, and Arizona is a state that offers free education for tribal members, so I'm really proud to say that. But thank you for the panel today, and my question relates to historical trauma. Recently, my team held some listening sessions with tribal organizations, and that came up as a really important thing to address in messaging around colorectal cancer screening. And I just wonder if you guys can share some of your successes in acknowledging the historical trauma in a way that is culturally appropriate.
I'll go on that. First of all, cancer is relatively new. There's, 544 federally recognized tribes, and in all different languages, there's not a word for cancer. So cancer is relatively new. But when I work with a lot of tribal clinics, again, staff turnaround, there's a lot of providers that are coming in and out. So the first thing we do is cultural competency for them, because understanding that historical trauma, that it's not just, we're just angry. It's just there really is a context, and I think it's important to understand that history. You know, like in California, our first governor had a bounty on Native Americans. So just really understanding that history for your state, for that tribe, it will help you understand a better understanding of the community you're working in. And so I think starting within your staff to do a cultural competency training is really vital.
I would just add to that in that this is an area that we are challenged to really take a hard look at. One of the tribal communities in our state at Fort Berthold has a tribal college, Nawada Hidatsa Sanish College at Newtown, North Dakota, who has focused their entire education system around trauma-informed care. And I think we have a lot to learn from them. I don't know that there's been a huge amount of information necessarily available specifically to colorectal cancer screening, but when we talk about things like fear of colonoscopy or of those invasive procedures or mistrust in the system or in Western medicine, we have a lot to learn in that area, and not only to understand it, but also to be able to apply it.
The only thing I'll add is that I think one of the strengths in Native communities is the sense of community. And I know with the COVID vaccination, you know, because people had knowledge of epidemics that had killed, you know, some communities, up to 80% of a community died in epidemics. And so they actually had super high COVID vaccination rates because people wanted to protect their elders, they want to protect their families. And I think that using some of that messaging of the strengths and resilience, you know, that these things have happened, and yet there's also a lot of ability to make really wonderful connections and build on that. And so, again, a lot of our messaging is around, you know, do it for your family. You know, this is something that we de-emphasize the scary cancer word and more talk about how it's an important thing. So I would just say that really thinking about what are the strengths and the great abilities that exist, and not just in Native communities, but other communities too. There's a lot of beauty, and so building that up, I think, can be really helpful.
I think I'll leave it with that, like ending on that strengths and resiliency, because we can talk about the trauma and we know what's there, and I think there's enough information out there, but we do, you know, that cumulative experience, but we also have our language and those ceremonies that have kept our relatives going and being able for us to use that today.
Thank you so much.
Hi, I'm Heather Dacus. I'm from the New York State Department of Health. First, I want to thank you all for coming here to teach us and leaving us with a little bit more, I think, hopefully, for myself, a more open mind and knowing all the things I still need to educate myself about. My question has to do with, I can't remember which one of you spoke to the disparity between the dollars spent on prison health versus the Indian Health Service. And I know, at least in New York State, I've learned during COVID that there's a very large advocacy community around prison health, and maybe the advocacy for that is why there's dollars there. And I'm just wondering if you all see a role for the roundtable or any of our organizations to be a louder voice at the national or state level around helping to increase funding for Indian Health Services. And I ask that because I also know we're about to see a lot of improvements to patient navigation, but we don't want to see the gain just in one type of health access. We want that ability to access patient navigation for Indian health. So anyway, I'm just wondering what role our roundtable is playing on that.
I can answer first, and I'm happy to hear from would love to hear from everybody. I think strength in numbers, right? Like, again, I look at, you know, the work we're doing and how many people, like, I know for our organization, we can't go to DC and advocate, but I think we can give information, and we definitely need more of it. So I definitely am welcome to folks being able to help advocate on the Hill, because there's different levels, right, of need as we think, you know, you talked about upstream, you know, that comes into play as well.
I'd say, you know, more and more I find that in my state, legislators come to us and, you know, they want information. They'd like to see what we are doing. And I do think success actually helps that. So when I can say, look, we've doubled our screening rate, but we still have more to go, what can you do to help? I think that those things really, that helps. And so the more that, you know, as a collective, that we advocate for screening in multiple communities, tribal and non-tribal, I think that makes a big difference.
I don't have a lot.
Yeah, I don't have a lot to say.
This question is for Diana. You mentioned the 70% colon cancer screening rate, and I hear that juxtaposed to the data that Becky just shared. And I'm curious if you can share more about that screening rate. Is that complete screening? Are most people screening by colonoscopy? Is it by stool-based test? If they're having an abnormal stool-based test, are they getting the follow-up? Because we know right now the colon cancer screening metric doesn't really reflect what should happen when people have non-invasive screening tests.
Yeah, good question. So 70%, that's behavioral risk factor surveillance system data. We also have data from medical records, which actually it's a little lower, but fairly close to that as well. So mostly that is colonoscopy. Our system has prioritized colonoscopies because of the higher rates of colorectal cancer. When we do stool tests with folks, about a quarter to 30% of them are positive, are abnormal. So then all of those people have to go on. So we just have higher amounts of colorectal cancer and precancer. So I would say the majority of that are, you know, our colonoscopies. That being said, we have been trying to increase the rates of other stool testing because, as I said, we have a backlog and a bottleneck in colonoscopies. So we face some of the same issues other places do in the colonoscopy follow-up to abnormal fits. I certainly would love, that's one of the things I really want to find out is what other people are doing to increase that. I think we have been doing some medical chart reviews in the different regions that we work, and to see what their rates of abnormal follow-up are. And we've been finding it's about 50 to 60%. So I actually am encouraged from seeing some of the earlier presentations that we're not far below some other people, but that's not good enough. It needs to be better.
Hi, Peter Liang from NYU and the VA New York Harbor. I had a follow-up question about the 70%, 72% rate that you mentioned, Diana. At first, I was curious whether it represented the entire kind of the community, but you're saying it's BRFSS, so it should. So is it just that it just recently reached that high and it was a very rapid increase, therefore we would expect to see the gains in incidence and mortality soon, or is there something else that you think the data could be, the mismatch between screening uptake and the incidence and mortality disparity that we see?
Oh goodness, I hope that it's just a time lag that that the next period we will find that it's actually starting to drive the mortality rates down. So far, we haven't seen that. I would say, as I said, and it's in the last 20 years that screening rate has increased. So since about 2010, it's is about 60%, and we've sort of seen a slight increase up to that rate. So I don't know. I say that in full disclosure that I would like to see that screening rate then be reflected in the mortality rate. And maybe it's just, we need more time, that, the next 10-year period we'll really see that. We have looked at survival, and one of the nice things is we are finding when people are diagnosed, then they get quickly seen for treatment. Their survival rates are similar to other populations. So once they get into the system, we just have more colorectal cancer. But once they're in, then we actually have pretty good outcomes. Comparatively, you aren't seeing that sort of access to care issue or survival differentials. So we're doing what we can, but it's still a question.
Sorry, gonna bend down a little bit just so I can get the mic just right. But my name's Richard Musso with Great Plains Tribal Leaders Health Board. We're based Rapid City, South Dakota. Work with 4 states, 18 tribal communities in North Dakota, South Dakota, Nebraska, and Iowa. Just want to first thank all of you for the moderation, Melissa, and then of course the presenters. I think you guys really brought up a lot of great topics and a lot of different dialogue that I think for us, will be really great to be able to expand on and be able to talk about, especially data, especially access issues. I know these are all things that we find challenging working with our communities as well. And I was going to just throw this kind of plug in a little bit too, but how many people in the room know about the role in colon? Does anybody know? So I see a few hands, but I would say for the last 10 years, other than funding, which is always great from CDC, or anything research that you can do, or anything that you can kind of do with partners, that's the other thing I was going to mention that we've found really helpful, is because you can go to different events and activities and be able to throw this huge inflatable colon, which I don't know if you guys know, but it's like the size of a playground. But for a lot of us that we enjoy CRC, right? Like, it's like the playground, just a visualization of CRC. But we find that this is important because it starts to get people talking and discussing what we all kind of call, somewhat of a fun issue, but on the other side, it can be a very challenging or maybe even a scary issue because maybe they had a relative that passed away or something along those lines. But I was gonna just kind of throw out this question of, I saw some humor in the different things, but what are some other ways that are really great to engage, community members, similarly that ultimately, can get us through some of those challenging topics?
Again, I'm always going to go back to culture is prevention, as much as we can, weaving in that culture so we could kind of close those care gaps. And then number 2 is being in the community. That is really huge. I know A lot of corporations have kind of downsized, compacted each other, and so it's not as easy to get to those rural tribal communities, but it's really important to our communities to see you there, to be there in the communities.
I would agree with that. We are very fortunate in all of our communities where, because they've built those relationships with tribal health educators and with public health, those staff have been able to be out in the community at the casinos, at Elders Day Out, at some of those celebrations, powwows and so forth. They've had the Roland Colon available there. They've been able to talk to people just in conversation rather than in this clinic setting where the expectation is that you're going to specifically be talking about that. They've been able to talk about it in much more casual ways and in ways that are more meaningful for them. And Richard, I want to just compliment you. We participated in the Great Plains Tribal Leaders Health Board partnership and cancer screening event that was held last May in Rapid City. And one of the probably most important parts of that meeting that was very meaningful to me was being able to be a part of the listening session where there were 75 or so 50 to 75-year-old Native people who were asked a series of questions. And it really helped us to understand how important family is, how important it is to relate this to the relatives of any one person, how to speak to the subject. And one of the things that came out of that I won't forget is just really how taboo of a subject it is to talk about your bowel movements or to talk about what those symptoms might be that are associated, and how important it really is to speak to prevention. And so I hope that one of the things that comes out of this is that we not only look at what the risk factors are and what the barriers are to screening, but what are the protective factors and how can we share those with members of those communities where that is one of the most important things that they can do to prevent cancer.
Yeah, I will definitely say having giant colons, I'm always impressed at how many people want to, take their picture and put it on Facebook of them in the giant colon. I have dressed as a polyp person and I've run in a 5K race. I can tell you it's very warm. I don't suggest it. But doing the things that yes, you are out in the community, you go to events, you go to bingo, you go to the fiddle dance, you just are where people are, the basketball games, and you have the conversations. And it doesn't have to be as clinical. It can just be like, hey, are you old enough? Have you had this done? Go chat with the health aide. You should, it's probably time. And it can be as simple as that. So I think having that ongoing dialogue and again, making it fun really makes a difference.
I think humor does play a big role in who we are as Native communities. And even just sitting with the folks from Great Plains, I didn't know one of the gentlemen, and he was talking about piercing his 4-year-old's daughter's ears, and we were like, oh my God, don't do that. Like, no, and didn't even know him, but we were joking about it, and that's just how laid back some of our communities are. And then I will give the one rule, don't go in looking like a federal employee. That, right? Like, we wear jeans to funerals, and that's just, how we're oftentimes we're a lot of relaxed in dress and not that, federal look. And then not to think about the trauma, but I'm in my mid-40s, and I would say 3 or 4 of my aunties and uncles are, boarding school survivors, have been sexually and physically abused, so we don't talk about, sex or our bodies. And so a lot of us grew up not having those conversations, and how we'll get squirmy if our provider brings it up. And so, for me is being able to really be able to heal from that and have a conversation with my daughter on things that I wasn't taught, and that's normal, and I see head shaking. So I'll just add those 3.
Just another quick question. Stoney Anderson, the California Colorectal Cancer Coalition, and we use a bouncy house company to blow up the giant colon because it weighs 200 pounds. And it's hard to move. But anyway, that's just for the colon, the big colon. But my question is, the HRSA website is so valuable for the uniform data set, looking up which federally qualified health centers need help in California to increase their screening rates. The Indian Health Service, can you send out the website or let us know how well does that website identify Indian Health Service clinics that need intervention and help, like in California or other places?
I mean, it's a federal website, so I don't think you'll get those details, but I could be wrong.
We found it very difficult to find tribal level data anywhere. Truly, our best resource for that has been the individual tribes themselves once we've gained their trust. And they're under no obligation to share that with us whatsoever. And in fact, one of the things that I think many people don't realize is that most tribal communities have their own IRB. And so if you are wanting to do research in those tribal communities, it's very important that you go through that organization, not just your own, academic IRB system, but also through those organizations.
We wouldn't be providing research, we would just be providing help. But because the reason I asked this question, because in Alaska, you're using the behavioral risk factor data set, which is a survey, and so, and that's your best source of information on screening, is that correct?
No, we also use hospital data. So we have Cerner and RPMS, electronic health record data. So when we're actually working with clinics, we can look at the screening rate by community. And in fact, we often use that. There's competitions between healthcare providers in different communities of, like, you were at a 51% and we're at 63%. So we do some of that by looking at the medical record data. But for national audiences, in order to have comparable data, we often use VRFIS.
So do you have many federally qualified health centers? Mm-hmm. And your uniform data set is up in the 60s also, or 70s?
I believe it is, although I would have to look at it again. I do know that in order to participate in the CDC colorectal cancer control program, our clinics needed to be a screening rate less than 60, and we had a couple of clinics that were above, but most were in the 50s, so in that range.
Thank you very much.
Wow. Well, we're going to wrap up this session, but a thought that came to me just listening to this panel is, and I usually tell this to my fellows, is, when you work at academic medical centers or those of us that are, care providers, we think we know best, right? Because we know the data and we have experience, and we go into communities and we tell them what they need, but we don't often listen to what they want or what their needs are, and really just listening and just going in and really understanding what individual communities need. If we needed, I can't think of a better example of our motto of 80% in every community than this panel was today. And I'm thinking back to last year when we did a similar Armchair panel in the African American community. So I learned a ton, I'm sure everybody else did, but this is how we get micro-granular. This is how we get into the communities and really understanding the beliefs, the trauma, the history, and the storytelling is so important, right? Getting people who have been screened to tell their story, just like we heard from survivors. So I want to thank you all for an absolutely engaging and incredible session. Before we applaud and thank you, let me just mention, we're going to transition now after a 15-minute break to the breakout sessions. Please go to your breakout rooms. And then you must join us on the second floor pool deck at 5 o'clock for a reception. So thank you all so much for your insights and for enlightening us.